I'm Dr. Amritaksha Deb. I'm a nephrologist and practice in Kolkata. Today we'll be talking about a modality of dialysis, that is hemodialysis. And we'll be talking about how we prepare for hemodialysis, when we prepare for hemodialysis, and when hemodialysis is initiated. So basically, hemodialysis happens to be one of the forms of renal replacement therapy. This should ideally not be called renal replacement therapy because we are not able to really replace the kidneys, but still it's a renal supportive therapy. This is only done in patients who have certain indications for starting it. But firstly, we would like to know what exactly is required to do hemodialysis. So for hemodialysis, we require a vascular access. Vascular access is basically a way through which we can withdraw blood that is sufficient in volume for us to run the machines, and that's a huge volume. We usually run the body's entire volume in less than half an hour in most of the patients. So we require to withdraw a large amount of blood and to send it back inside the body. And to do that, basically in India, we have basic two options. The first option is the better option, that is a AV fistula. So what exactly is a AV fistula? Basically, we just join an artery with a vein, and due to the joining, what happens, the venous flow increases, and then we are able to put in a needle inside the vein and withdraw blood sufficiently to run the dialysis procedure and again return the blood through the same vein. This is, as we do not have any foreign body inside our body, this is a good access, and this is the best form of access for doing hemodialysis. Now we have 4 or 5 sites where we can make a AV fistula. It's usually made in the non-dominant hand, that is the hand that we frequently do not use, that is the left hand. So the veins of the left hand are to be preserved, otherwise we would have no access. Preferably we should preserve the large veins of both the hands so that we have multiple sites for making fistula, and that is because this procedure is hampered by a huge failure rate. In spite of having veins that are amenable to making fistulas, they still fail, and the failure rate can be up to 50% of those that are made. So we are not to be disheartened and we have to try again. So when we feel that a person is going to need dialysis, we should plan the access right then and there so that the access can be made. If there is a failure, we have adequate time to make a access once again or to plan alternative access. The other accesses that are used here are basically catheters. They are basically pipes that we put inside the heart, and they have 2 ends, arterial end and a venous end so-called, so that we can withdraw blood through it and send blood back inside the body. But these are foreign bodies and are prone to infections. There is a tunneled catheter that is used, that can be used for a prolonged period of time, or we have a non-tunneled simple emergency catheters. Their use are to be minimized in chronic kidney disease patients as far as possible. Besides this, we have also AV shunts which were used at a point of time which are no longer in use, and AV grafts which are little expensive and not much of exposure of our dialysis staff to this, so they are hardly used. So we are just with these modalities. Now the issue is, when do we initiate dialysis? So firstly, we are talking about chronic kidney disease, not acute kidney disease, because acute kidney disease is more of an inpatient problem. So outdoor basis, we have chronic kidney disease. It's usually not the urea creatinine values or not even the calculated GFR. It is basically a milieu of symptoms which is called the uremic symptom. So uremic symptoms, once present, indicate that we need dialysis. They are usually loss of appetite, having weight loss gradually over time, and generalized ill-being. So we can initiate dialysis in these patients. Other than that, we have got other urgent or emergent indications, that is development of hyperkalemia, severe hyperphosphatemia, or severe anemia that is refractory or that does not respond to medicines that we are giving. In addition, we also have uremic encephalopathy, that is the involvement of the brain due to urea, uremic pericarditis, in which we have the heart's outer layer being inflamed because of uremia, and we have uremic bleeding, that is bleeding diathesis due to high urea levels. In all these conditions, we are to initiate dialysis emergently. But ideally, it should not be emergency procedure because kidney disease gives us adequate time. It gives us adequate warning. So once we have the warning, we are to initiate dialysis electively. That is better in both regards, because if you get sick, you are admitted to the ICU, you are admitted to the hospital. Your disease does not get cured, but you lose a lot of money, you lose a bit of your health. So it's much better that you initiate dialysis once you have the symptoms. Usually there is no indication in beginning dialysis just based on GFR values or just creatinine values, and begin it in time, knowing full well that you're going to do well in dialysis. You will get a number of years of life through dialysis, but it has to be done at least twice to three times weekly. And dialysis does not cure the kidney disease. It just provides supportive therapy. That is, we are cleaning the blood through dialysis. Thank you.